Adler, who is a psychologist at the James H. Quillen VA Medical Center. She also holds joint appointments as full-time VA academic appointment, assistant professor in the Department of Psychiatry and Behavioral Medicine here at ETSU, as well as a clinical assistant professor in the Department of Internal Medicine here at ETSU in the College of Medicine. She has a BS in psychology from the University of Santa Clara, Ph.D. in clinical psychology from the University of Albany, I guess that's SUNY Albany? SUNY Albany. And did her postdoctoral fellowship in health psychology at Ohio State University Medical Center. She wanted me to make note that she has also been on the VA Medical Center Ethics Committee for 20 plus years, and today she's here to discuss ethical issues in end-of-life care. And so, welcome. Thank you.
Okay, thank you. Hopefully, is the sound okay with this? Hopefully, we will get a little bit of discussion. I know this is not a great type of room to have a lot of intimate discussion, but we're going to be talking about ethics and talking about issues where there's not necessarily one right answer. So, when we get to those places, hopefully just feel free to raise your hand or shout out, and we'll all be able to kind of hear what other people's thoughts are. My obligatory slide. And just kind of to get started, what I plan to do is just give a brief overview of biomedical ethics, talking more about what decision-making capacity is and isn't, and capacity issues in end-of-life care. And I'm going to really kind of focus on capacity issues today because as mental health professionals, that is one of the ethical issues where we seem to most often find ourselves involved. And then lastly, what we're going to be spending most time, and probably the most interesting time, will be looking at some specific cases, some of which you are familiar with. These are kind of hot button issues in the public, and then some brand new things that you may not yet have even heard of, where we'll be looking at what some of the potential ethical issues are. Now in 2014, the Institute of Medicine produced a report called Dying in America. Make sure I get this correct. Dying in America, Improving Quality and Enhancing Individual Preferences Near the End of Life. And what that report did was really highlight some of the dangers of if we do not have effective end-of-life planning. We end up seeing things like soaring medical costs, people getting way too aggressive care and too much care near the end of life that they didn't necessarily want. And so this report recommended really that we need to be having these conversations sooner. We need to be getting these things done, and really was a big push on physicians to institute end-of-life care conversations. What the report didn't really address is the fact that having the conversation is really only one piece of this puzzle. So not only do you have to get the conversation started, but you have to be able to make sure that the other individual on the end of the conversation is able to fully participate, or if not that individual, that you've got an appropriate surrogate, or really you're not going to get anywhere with the end-of-life planning. Now to review, or if not review for you, we're going to kind of cover it briefly. The 4 cardinal principles in biomedical ethics. In other words, the aspects that should be present in any kind of medical procedure, intervention, research study, any kind of contact we have with individuals should include these 4 principles. The first being autonomy, that individuals have the right to independent thought and action. Beneficence, we should be striving for a net benefit for that individual, and individuals have the right to strive for what they see as being the best outcome for themselves. The third, justice. There should be an equal distribution of burdens and benefits for that individual and for society. And lastly, non-maleficence. The individual should not experience harm as a result of this action or treatment. nor should society bear an excess burden because of that choice. All right, now keep all those four in mind. We're going to be coming back to those. Now, for the purpose of decision making specifically, we're going to be looking mostly at two of those principles, and those are autonomy and beneficence. Those are the two that are always present in issues about decision making. And for mental health professionals, these are the ones that we are most often asked to weigh in on. In 2014, there was a survey of hospitals that showed that the most common reasons for ethics consultations were issues of capacity and issues of informed consent. All right, so in order for somebody to be able to make an autonomous decision, you have to be able to demonstrate the capacity to understand the relevant information, the capacity to manipulate that information in a rational way, the capacity to appreciate that information in a way that's individual to that person and to their situation. And lastly, you have to have the capacity to communicate that decision in some way. For some folks, it's not always going to be spoken language, but you do have to have that ability to communicate your choice. Now, people who fall short of these criteria are said to lack decision-making capacity to one degree or another, and this is where it begins to get pretty gray. So we're going to go ahead and have a little bit of a quiz. So feel free and brave to shout out your answers. And I plan to be a good behavioral psychologist and have a bag of leftover Halloween candy to toss out to people, whether or not you had a correct answer, just to get you to participate. But unfortunately, that candy is still resting comfortably at home where my children will be quite happy. All right. First one. The terms decision-making capacity and competency can be used interchangeably. True or false? All right, very good. Candy for everybody. And that is because incompetence is a legal term. Incompetence has to do with a court decision or a judge's decision about whether or not the person lacks the ability to make valid decisions, whereas decision-making capacity refers to that individual's ability to understand and appreciate the nature and consequences of their decisions and formulate and communicate decisions, and that's determined by a clinical assessment. It's determined by a clinician rather than by a court. All right, next one. Lack of decision-making capacity should be presumed when patients go against medical advice. True or false? Myra Elder, you're laughing. But that is in fact the number one reason for requests for capacity assessments by physicians is when a patient objects to a course of action. In general, the rule of thumb is that we want to make sure that we're assessing people that are at greatest risk of cognitive impairment, either because of their medical conditions, and when the risks of the intervention are particularly high related to the expected benefits. For example, there was a gentleman I saw a few months ago on the acute ward of the hospital, who was 55 years old, white male, had a history of bipolar illness, substance abuse, type 1 diabetes, and non-compliance. And at the time that I was called in, he was refusing insulin. So this is obviously a case where the stakes were high for this person. So this was one where his team wanted to ensure that this individual really understood the consequences of this potential decision. All right. Does decisional capacity in one area imply that you have it in another? No. Okay. And that is because there are so many different types of decisional capacity. I think the general public kind of looks at this as there's just, good brain, bad brain. You can make decisions, you can't make decisions. When actually it's much more complicated than that. There are decision-making capacities for whether or not you are able to participate in research, whether or not you can consent to treatment, whether or not you have the ability to create a will, whether or not you have the ability to stand up for trial. Each and every one of those require a somewhat different skill set. So saying that somebody has, decision-making capacity to make medical decisions doesn't necessarily tell us anything about that person's ability to handle their finances. A little bit of history, I will tell you, when I first came to the VA, the requests for capacity evals were actually termed competency assessments. And one of the big jobs of the Psychology and Psychiatry Service and the Ethics Committee was to try to instruct, and try to teach the providers that were requesting these, no, this is not competency, this is capacity, and to please specify what is the capacity that you're interested in, so we can provide the assessment that's going to be accurate. Now, capacity also waxes and wanes. Oftentimes you see it so that my financial decision-making capacity may be declining, even though my medical decision-making capacity may stay somewhat intact at a time. I can think of a gentleman that I was taking care of in the community living center at the VA who was quite a well-educated person. He was elderly, in his early 80s, but had quite a high level of premorbid intellectual functioning. He had been diabetic for a lot of years and had taken a lot of pride in maintaining very tight control of his blood glucose, understood the impact of using his insulin and his diet, and he was still very much on top of all those things, even as his vascular dementia was progressing. So he was still able to participate very well in terms of his medical decisions regarding the management of his diabetes, even though he really needed a great deal of assistance in terms of things like long-range financial planning, where he really lacked insight and wasn't able to process or think about the impact of his choices in that area. Ultimately, our goal is that we want to empower people for all of the decisions that they have the capacity for. All right, next question. Individuals with certain psychiatric conditions should be presumed to lack decisional capacity. Okay. Would anybody say true? Are there any conditions that you would say we should assume that person lacks capacity? Okay, that's a good one, John. And even that, I would say that's probably one of your safest bets, but you'd probably have to weigh it on a case-by-case basis, because even that individual may demonstrate a restricted level of decision-making within a certain realm. But unfortunately, individuals with certain diagnostic categories sometimes get penalized, and the assumption is, all right, they have a diagnosis of schizophrenia, they have a diagnosis of bipolar disorder or moderate dementia. We would assume that they lack capacity, where really this is a case-by-case basis where we want to assess them. But certainly these things do raise our index of suspicion. When we see things like delirium, dementia, thought disorders, metabolic disorders, and as Dr. Thurman mentioned, and developmental disorders, those are ones where we really do want to make sure that we're doing an accurate assessment. And that we ensure that that individual is able to make their own decisions to the degree that they're able. This next one. Only mental health professionals can assess decision-making capacity. True or false? Yeah. False, but this is a really unpopular sentiment in many areas. Often I find in the medical center, this is not the answer that the medical team wants to hear. And after all, who wants to potentially be the bad guy, the one to be delivering news about restricting this person's decisional authority, or help finding, or going through the arduous process of trying to find surrogate decision makers when somebody does lack capacity? Ideally, the person who is in the best position to make determinations about that individual's decision-making capacity is the one who has the longest term or the deepest relationship with this person. And that isn't always necessarily even the physician, although decision-making generally does require a clinical judgment. Mental health professionals in general, we are all best suited for assessments of decision-making when the person's questionable capacity is the result of mental illness, or in cases where it's likely that neurocognitive assessment is going to be something that's going to be helpful or desirable. Unfortunately, there is no gold standard on what is an excellent assessment of decisional capacity, or what should everybody get in terms of assessing decisional capacity. And as a result, it's kind of informal and inconsistent oftentimes. Under ideal circumstances, myself and many of us would start with or would want to do a formal clinical interview, and in that interview we'd be including a formal assessment of mental status. We'd be assessing psychosocial factors, perhaps interviewing informants. We'd want to know what the patient's thoughts were about what was going on. Did they recognize deficits? Do they have a plan, or that they would cope with those things or address those issues? And lastly, what are their patterns of behavior or values in the past? Is their current behavior consistent with these? I'd want to assess their cognitive abilities. I'd want to include realms of attention and concentration, because these are relevant to things like how somebody understands and processes information. We almost always want to do some kind of assessment of memory, because if somebody doesn't have the ability to consolidate and retrieve information, how are they going to be able to hold information in order to make a decision? We want to check out their reasoning and problem-solving ability, because again, we need to know, is this somebody who is able to manipulate information and manipulate a variety of options in order to arrive at a decision. And lastly, there has to be some assessment of language abilities, because they do need to communicate in some way what their choices are. But what do you do in a situation that's not the ideal situation? And frankly, this is where most of us are working. Non-ideal situations where we may be seeing people who are extremely ill, frail, perhaps nearing the end of life. I don't want the assessment of their decision-making capacity to be something that is burdensome, painful, something that is taxing or creates a great deal of stress or physical stress for them. But on the other hand, I want to try to give them their best shot at making sure that they are able to participate in these very key decisions, especially near the end of life. So what I try to strive for is something that's, rather than a formal, maybe a formal assessment, it's a bit more something like a goals of care conversation or discussion. An informal assessment of mental status includes things like, rather than tell me who the president is or exactly what the calendar date is, questions like, can you tell me how you got here? What was going on at home before you came in? Who's with you at home? What's that like? Something that helps me get not only a sense for their psychosocial relationships, but also kind of their relationship to time. In that answer, they may give me things about time orientation. They also are going to give me some information about their values, who's important to them, what's important to them. Thorough assessment of their psychosocial factors and interviewing the informants. When I'm working with people that are very ill or working with people near the end of life, this is a really critical piece, but it is risky, because now we are potentially dealing with hidden agendas and other family members who may have reasons for wanting somebody to look as if they do or do not have decision-making capacity. I have also found that individuals don't always behave in front of their family members the way they behave apart from their family members. There was a gentleman over in the community living center in our hospice program, very bright guy. In fact, he was a published author, had a doctorate, and was just quite a fascinating individual with a very, very volatile relationship with his wife. In her presence, he regressed to the point where he was incontinent and refused to self-feed. So if you only came in and met him when his wife was there, you might talk to this individual and feel that he was not capable of the kinds of things that he certainly seemed capable of as soon as she left the room. What is the patient's perception of the problem? I like to ask them, what do you think is going on? What's happening? What do you want to see done about it? And lastly, these three questions are probably the most important ones that I have found in working in end-of-life care. This is kind of the down and dirty assessment. If you have nothing else, no other time to ask anything else, ask these three. What do you most want to see happen here? What do you most want to avoid? And what's been the most important things to you in your life? If the individual themselves is not able to communicate, then I'm asking the surrogate these questions for the patient. One of our interns was with me a few days ago talking to the wife of a patient who was in the ICU, asking her, what would your husband most want to see happen here? Asking for that substituted judgment. It's not perfect. Of course, those hidden agendas are going to potentially be there, but for many people, what they will tell you in that point is, I know he wants this, but I want such and such. So at least that gives you the lay of the land. So I have kind of borrowed from this very streamlined model that has the nice helpful acronym, you are a capable decision maker. If you can understand what you've been told about the situation, if you can tell us how you reached that decision, if you can demonstrate an awareness and appreciation of how doing or not doing, following through or not following through this course of action would affect your life. Again, that's how does it relate to your own personal beliefs and values, and if you can communicate that choice. This is a model that I have shared with a lot of other non-mental health or physician providers. The boots on the ground staff who spend a great deal of time in the presence of the patient and their family. Social workers, nursing staff. These people may not necessarily be doing the formal assessment of capacity, but they're in a great position to ask these questions and give me feedback about what information they gathered from these questions. All right, so if this were a perfect world, we would have optimally competent people understanding their risks, their benefits, and being able to express choices that were consistent with their goals and values. But of course, we know that's not a perfect world. So we're going to talk now about some ethical dilemmas, and I'm sure you're going to recognize some of these ones. They have been powerful and popular in the media. And what I want to do is see if you all can identify some of those potential ethical issues, going back to those ideas of autonomy, beneficence, justice, non-maleficence. See if you can spot any of the issues where those might be involved in these cases. All right. Anybody recognize this person? She's been out of the press for a little bit of time. This is the lovely Brittany Maynard. Brittany Maynard was at this time 29-year-old woman, married, diagnosed in January of 2014 with a non-resectable brain tumor. And while initially she sought very aggressive treatment, she was having intractable seizures, went through courses of medication, tried her best with her and her husband to sort out what might be done. And really, there was, surgery was not an option, and medications were failing to control her symptoms in a way that she felt like her quality of life was going to be acceptable to her. Now, she was a California resident, but what she elected to do was to move to Oregon, where she could exercise that state's death with dignity law. And she did do this very publicly. Went on, if you may have noticed, that picture that I had came from People magazine. I mean, she was splashing around everywhere in an effort to try to bring attention to not only the fact that most states in the country do not have death with dignity laws, but also she recognized as a young person she faced particular challenges in this area. And then so she did actually utilize her rights under death with dignity and ended her life in November of 2014. All right, any of those 4 ethical principles jump out? Might be going on in this case. Autonomy, excellent. Yeah, autonomy, she executed her autonomy. The flip side of autonomy is sometimes viewed as paternalism. And maybe not surprisingly, she got an incredible amount of criticism from, of course, complete strangers who were arguing that at 29 years old, she needed to fight for every last bitter second of life. She had her life before her, no matter how brief it might be, and that really it was her responsibility to live it out. So kind of warring against autonomy is that idea that somebody else has a belief that you should do something else that they feel would be in your best interest. And research has shown that terminally ill young people, in fact, get the most aggressive care at end of life. They report the greatest level of suffering, and their families report higher levels of depression and PTSD after their deaths. So it really seems that in our society, even though they may have the right to decline aggressive care, there is a paternalistic emphasis to throw everything at them, whether or not they want it. Any other issues? I'll throw one up here for you. What about justice? And remembering justice is that idea of kind of equal access. What happens if you are a young person or an older person who has a terminal illness and feel that you want to exercise a death with dignity, and you don't live in California, Oregon, Washington, or Vermont, and you can't afford to move? She had that ability. If we look at this in terms of principles of ethics, this is not something that's really available to everybody. There was a study done by the New England Journal of Medicine showing, and I did, unfortunately, I used the incorrect term. This is not assisted suicide. This is death with dignity, where you execute the death on your own without something like Dr. Kevorkian stepping in and doing it for you. But the study looked at individuals who exercised that right to explore the death with dignity and then went ahead and did end their lives, and found out that they were kind of a pretty slim minority, that most all of them were white, older, very well educated, and above all valued maintaining their autonomy. So if you think about all of the people who may want to consider ending their lives when they are faced with a terminal illness, it's a very small and select fraction, a minority, who actually carry it out. So while it is legal in certain states and considered ethically permissible, kind of my take on all this is it's certainly not widely available to everyone, or doesn't appear to be widely used. Now, Brittany Maynard was able to execute her end-of-life wishes independently. And actually, that was one of the things that she talked about, kind of interestingly, is she almost thought she waited too long once. She ended up having a very bad seizure, was hospitalized, was unresponsive for a period of time, and her family was concerned that she was not going to be able to follow through with her wishes as she wanted, because she was very disabled yet not on life support, and they did not want to see her kind of stranded in that limbo. She did regain enough function that she was able to go ahead and utilize the medication to end her life at a time that she chose. But what happens if you do wait too long? What happens if you make a decision now that some point down the road, when you are incapacitated to a certain level, say when you no longer recognize your children, or you are no longer able to enjoy your favorite TV shows, that at that point you decide that you will feel that your life has not sufficient quality to want to continue to live. If you say something like that down the road, you now are in a situation where you're going to be dependent on somebody else to carry out those wishes. So what I'm going to talk to you about now is a case you probably are not as familiar with, although this is also very public in Canada. And this is the case of Margaret Bentley. And the concept here is called voluntarily stopping eating and drinking. Margaret is, at this time, an 84-year-old Caucasian married female. She is a retired nurse. And in 1991, Margaret created a living will stating that she wanted to voluntarily stop eating and drinking at the point that she felt she was too disabled. And granted, you can see that that's a pretty wide open term. She did indicate to her family that that meant things like, if I don't recognize you anymore, that is too disabled. A number of years later, she was in fact diagnosed with Alzheimer's. She had a very loving, supporting family, cared for her in the home for many years, then had home health come in, helped care for her for a number of years. When that became too difficult, she was put in a community nursing home, and she continued to decline as everybody expected, but then she kind of leveled off at a place and didn't die as the family had thought that she would. And she was kind of stuck in this place where the family thought, ooh, it doesn't look like her quality of life is what she would have considered good. She's not recognizing us, she's not doing the things that she used to enjoy. It's time for us to execute her living will. The trouble was that the community nursing home staff didn't agree with that. Some of the ethical issues here. Autonomy, again, as I said before, with issues of decision making, in that autonomy is always going to be primary. Which self gets to decide? One of the things that happens with dementia is that your self becomes simpler, and your needs and wishes and desires kind of concurrently become simpler from, say, your current self. So we have a situation where her original self made plans, but her current self is now in a different place. Who wins? How about the non-maleficence? Do no harm. The family, as I said, if you wait too long, somebody else has to step in. The family was saying, she said she didn't want to be fed. Well, actually what she said was she wanted to voluntarily stop eating and drinking, and that's kind of where the battle ensued because the nursing home staff said, if we hold a spoon up to her mouth, she opens it. The family said, well, that's a reflex. And they actually videoed that if you hold a spoon up to her mouth, she opened her mouth. If you held a book up to her mouth, she'd open her mouth. If you put your finger up to her mouth, she'd open her mouth. They took that to court, and the judge initially said, you're right, that's a reflex, and wanted to find in favor of the family. But then the community nursing home staff said, no, this is cruel. Our staff cannot refuse to feed a person who will eat. We're not force feeding her. And so this issue went back and forth in the courts, with the family feeling terrible that this is not honoring this woman's wishes, the wishes of her more complicated self, and the community nursing home staff saying, you cannot force us to do something that's cruel and unusual. We will not withhold food from somebody who is wanting food. So this information was sent to the Hastings Center, which is kind of an ethics think tank. And a number of prominent ethicists all debated this. You have any idea what their conclusion was?
Just have to simply take their mother home and not do like a practical thing.
That would be an excellent point. No, actually, you're making me think, Andrew. That would be, I'm not sure why they didn't do that, although I can think of other cases where, oh, I'm blanking on her name, the Florida case. Yes, Terry Schiavo, where by that time, you know, it's almost as if many people feel they have a right to jump in and protect this person, to ensure that their rights are being upheld. Had they foreseen this coming, probably they would have simply done whatever they had to do to keep her at home and not feed her, because she wasn't asking for food, but she was not turning down food. And so the family was, when she would seem to reach out for food, the family was reminding her, remember, Mama, you didn't want to eat when you got to this point. And the nursing home staff, they all were kind of putting that in the category of, this is cruel. You're harassing this poor woman. The outcome of the Hastings Center debate was actually that if a person's, let me see how they phrased this. If the family's actions, if the family's behaviors, even well-intentioned, go against the apparent wishes of this simpler self, then trying to hold her to the original agreement was a distortion of respecting autonomy. And their conclusion was that everybody has the right to assent or agree to voluntary feeding. Now, if she was locking up her mouth or something when they were trying to feed her, that would be a different case. But as long as she was voluntarily eating, the ethicist said, then really we need to abide by the rights of the simplest self, the present self. Yeah.
When you say holding up to the mouth, you mean actually holding food up
So that she could see it, smell it. That I don't know. I don't know the actual distance, but I do know, she's sighted, and that presumably has still a sense of smell intact to some extent. They were feeding her as they would feed any other resident. So it wasn't just like putting a meal tray down in front of her. It was actually taking a spoon up to her mouth, like you might feed a baby. And I looked this up just a few days ago, or a week or so ago. This is still in the Canadian court system being debated. So, the family is still feeling as if her wishes are not being respected. The nursing home is probably still feeling that they are respecting the rights of that simple self in their care. All right, now I want you to consider a new company called Vital Decisions, and this is a real company. Vital Decisions provides advanced care planning, where their goal is that they're going to start these end-of-life care conversations early to try to reduce the likelihood of all of this unwanted, expensive, aggressive care. In other words, that Institute of Medicine goal that we talked about early. Does that sound good? Well, what if you knew that these conversations were started by somebody who you don't know and have never met? The person is employed by your insurance company, and the only things they know about you are that you are very ill. So this was a story I heard on NPR, and I couldn't get the link to work, but it's a really interesting one if you're into podcasts, to look this one up and check this one out. The idea is great, but in actuality, I think there's a potential for lots of risks. The company, Vital Decisions, is hired by different insurance companies. It employs primarily social workers, people who have skills at talking to people who are sensitive. And what they do is, when the insurance company gets a claim stating, John Brown just got a pathology report back that shows that he has a big colon mass, which has already spread. The insurance company then contacts this company and say, will you please send out a letter to John Brown talking about his end-of-life preferences. So John hasn't asked for this, and it's not brought up by his doctor or anybody else he knows. He gets a letter in the mail inviting him to call Vital Decisions. If he doesn't call in 2 weeks, they call him. They cold call. So, some of the ethical issues here. Yeah, well, autonomy is certainly one, and I'm going to get to that one. What about justice? This is, again, equal access. The first thing I thought of is, well, if we're going to be positive, there certainly are benefits in having these conversations. And it's true that not everybody wants really aggressive care near the end of life, and that if somebody had initiated those conversations, they might not end up in the ICU having resuscitative efforts that they never wanted. But if your insurance company doesn't use Vital Decisions and somebody else's does, then you're not going to get the benefit of that if you consider it a benefit. If you don't consider it a benefit, but your insurance company happens to use this, then you're going to get picked on because your insurance company is using this for, well, look at the beneficence and non-maleficence. We don't know what reasons. Are they using this purely because they think this is a good thing, that they do want to have these conversations started early? Or are there, do they have hidden agendas? Are they working on reducing their bottom line? That if we can get people to take less care in the future, then we're going to be paying out less, and, that's in their best interest. So I think, among ethicists that have considered this particular company, they looked at this and thought, well, there's good and bad here too, but there certainly is potential for bias. And unless you know what basically it shouldn't be run by insurance companies. Vital Decisions might be a great company if it ran independently and was not getting information from insurance companies. It might be a better idea. And then, as some of you mentioned, the idea of autonomy. We don't really know if you are the social worker employed by this company and you just get a name to call John Brown because he has metastatic colon cancer. You have no idea if John Brown is demented, if John Brown is able to make his own decisions, if John Brown is severely depressed and suicidal as a result of this diagnosis, is he in a place where he is even capable of making a rational, well-thought decision? And how can they know that on a phone call where they don't have any of that information? All right, this next one. This is the last one, and this is the cutting edge, just came out, in fact, not even available yet. Meet Cake. Cake is a new app that's currently in beta testing. And I don't know if you can read that or not. What it says is, when I am gone, I would like my Facebook profile to be deleted. The purpose for Cake is an app to enable people to set end-of-life preferences on the go. This is something you didn't know we needed. But according to the co-founder of Cake, this was her take on this, was advanced care planning is one of the biggest critical needs in healthcare today. It's hard for us to talk about mortality, and right now the only tools out there feel like a chore or something you dread bringing up. There should be better tools to help people talk about this. Well, I hardly agree with her that there should be better tools to help people talk about it, but I'm not entirely sure that Cake is it. It was named Cake because the co-founders, I kid you not, this is a real thing. It was named Cake because the co-founders intended this to be something that was easy as cake. And at 35 yes/no questions, that's pretty darn easy. It was also meant to be celebratory. This was something that you could do kind of as a, hey, let's plan how you want to go out. One of the questions is, I'd like people to have a stiff drink in my memory. And as I said, you know, the 35 yes/no questions, and it boils it down into, I think, 6 different categories. Things like financial planning, medical planning, social things like unplugging or not unplugging your Facebook account, things like that. And the authors or the co-founders of this actually envisioned this as something that, you know, you could do when you're sitting there in the doctor's office waiting for your results, and you're thinking, oh, I might like that song played at my funeral that you hear on the music. Or you're having a sleepless night and you're beginning to wonder, you know, some of these questions, that they wanted it to be something you could quickly just kind of plunk in. All right. Now, it might meet a need, and the app itself is designed to be free, but they're planning on charging a $100 fee for a concierge, basically a death concierge, who connects you to different services that have been identified by your profile on your 35 different questions. Somebody who helps put you in touch with the funeral home or the financial planner or whatever your need may be. And one of my concerns with that is all those people already exist, and you don't need to pay $100 to get in touch with them. But yeah, ethical concerns about the making money off of this is a little bit questionable. Other ethical issues. What are people's initial thoughts about this app? Yeah, how serious is this? Access, exactly. I mean, if I like this idea but I don't have a smartphone, can I make my Cake profile? You know, if I really wanted one, then I may be out of luck if I cannot afford a smartphone, or if my postings are not accessible to somebody else. So as you mentioned, justice and access issues. Autonomy. Again, if somebody is, as the authors suggest, you know, doing this in the heat of their anxiety, waiting for their medical results, is that really the time that you want somebody to be making these kind of weighty decisions? The idea about a stiff drink might be less significant, but they also ask questions like, I would like to be cremated, or I would like to be buried. And those are not necessarily decisions that someone should make at a time that they are emotionally distraught. People are also able to create this profile, kind of like the idea with the vital decisions. We have no idea what their mental status is, what their decision-making capacity is. Any potential for harm, do you think? Yeah, somebody else. And I know this from my 18-year-old daughter. People routinely grab other people's phones and fill out things, and change your keyboard to Chinese, or change your Siri voice and all that kind of stuff. Why not mess with somebody's cake profile? And actually, I did my own beta testing and asked my 18-year-old, just out of young, wired person, out of curiosity, what were her thoughts on this? And she actually thought, she said, that sounds too casual. Is this something that you really want to do on the go? And as somebody who's been a longtime member of the ethics committee, my concern is, while social media has become such an important part of our culture, it's not the same thing as a conversation where you sit down and people who may be in a position to be making your decisions for you don't necessarily know what your thoughts are. So we are all the time talking to people about, sit down and talk over with your surrogates what you want. Because this doesn't imply any sort of conversation. This is simply a posting, and as far as I'm concerned, and maybe it's just old-timey, but I don't see the posting as constituting, really providing any more information, than right now when somebody says, oh, Daddy told me last week that he wanted such and such. There's some value in that, but I don't necessarily see this as being any more legitimate. Yes, and they do. And that's another excellent question. Is this, what are their motives? Do they have, does cake get kickbacks from all these other companies? Are they going to, move the profiles in such a way to shovel business towards certain directions? So when I saw this, I'm a member of the Association of Death Education and Counselors, and I got a news bulletin last week that this was in testing, and thought, well, that's timely. I'm going to stick this one in right now. So this is kind of state of the art, but the kinds of things that likely we will see. As I mentioned, I do agree that it is important to be having end-of-life care conversations earlier, more frequently, more in-depth, more with the providers that you spend the most time with, not waiting till it's a consultant who just met you in the hospital. But I think as time goes on, we're going to see lots of efforts to try to bring these things about, and some will be really good and some may not be quite as good. So kind of in conclusion, I've got a quote from a young psychologist who was terminally ill and actually elected to end his life with a Washington death with dignity law. Birth and death may not be pretty or pleasant, but we can still be proud of how we handle them. So for all of us that are involved in helping people make decisions or ensuring that they are able to make autonomous decisions to the degree possible, I look at this as just kind of a point of hopefulness. And thank you for your attention. I guess we have a couple minutes if there's any questions or comments.
Could we have it on the microphone? We're broadcasting this and recording.
Yeah, in a case of clear diminished capacity in a nursing home, what are the implications for care and care decisions, maybe where there's family members who are POAs?
I'd be looking for a few more details.
Like, for example, you mentioned a case of a patient who's refusing insulin or dialysis, and we've got clear evidence of diminished capacity, and family members who have been identified as
surrogates.
Yeah, sure. And so what are the implications there as far as how the treatment team is going to pursue treatment?
That's
what
good.
levels of advocacy or paternalism would be appropriate?
The first thing that we would do, and again, working with an integrated healthcare team, I'm going to be, working with the social worker and other staff to find out, is there any evidence that this person has ever had a living will or any kind of advance directive where they spelled out treatment preferences. And now you can't foresee every possible intervention that somebody might be offered at end of life, but if you can say, let's say this individual has a do not resuscitate order, that they had said at some point when they had decision-making capacity, I would not want extraneous measures used to restart my heart or to keep me alive. I don't want to be in a ventilator. I don't want to have that, don't want a ventilator, don't want to have an aggressive CPR attempt. Now, if that's all we know, we don't necessarily know, would they want a feeding tube? Would they want dialysis? Would they want IV antibiotics? But we do know that's a place to start, at least talking with those surrogate decision makers. Why might your father, brother, husband, whatever, has said that he would not want those measures taken? And if they start saying things like, well, he said when the good Lord told him it was time, then we can then you might frame that as, what do you think he saw as an indication that it was his time? If his kidneys stopped working, is that like if his heart stops working, or is that different? Always trying to work from understanding what are their values and what kinds of decisions and priorities have they had in the past. Sometimes we do look at conversations and say, sometimes people may say, we were watching some Hallmark movie and somebody was involved in a terrible car accident, and there they were a vegetable and they were on life support, and Daddy said, don't ever let me get like that. I've talked with people before who feel very confident that they can make that decision for somebody knowing that they expressed that preference to them. So while you can't necessarily go to the individual, assuming that they're so compromised that they can't really participate in your discussion, look for other evidence of other decisions. What has been, important for them? Why have they made the choices that they made? Do they value life above everything? One of our interns, Amelia, was with me a couple days ago when we went and saw an individual who is very near the end of life, but has chosen to continue to go through dialysis, largely because his wife wanted him to continue to go through dialysis. And she looks at that as, she recognizes she is kind of in a bind, because while he doesn't necessarily want it, she wants him to live as long as he possibly can. And she knows that he has a very bad heart, he has multi-system organ failure, dialysis alone is not going to keep him alive, and she does not want him resuscitated, but for her, she wants to continue that piece. So even though that decision doesn't necessarily make a lot of sense to us, she can kind of explain how that fits into her beliefs and values, and he has been agreeable to doing that. And so his hospice plan actually included palliative dialysis, which is a pretty unusual course. Andrew?
So the cake example and the insurance company example puts into question this profit, this motivation for profit for both of these entities. And for what you do at the VA, making a decision or a conclusion based upon your interview with the patient is one thing, because you work for a federal institution, but I wonder, for a psychologist that's either contracted by or salaried by a private hospital, if there's any question as to the decisions that psychologist made, if there's any questions to the ethics of those sorts of decisions, or if a patient has the right to, or the family has the right to request a second psychologist,
sure.
a second opinion, and if so, if the insurance company or whomever would be bound to provide that without charging extra or whatever.
Yeah, that's a good question. I think we run into the same kinds of potential dual relationships with things like, you know, when you do Social Security evaluations and things like that. And generally, you know, we don't do those evaluations on patients that we take care of, but we're also, you know, we're not being, let me back up. You know, I think you're right that it would make a difference in terms of who is paying the salary of the person. There are certainly lots of mental health professionals that are, you know, they are subject matter experts and paid to testify, or basically paid to produce certain pieces of work or certain evaluations. But that's, you know, it's a kind of a slippery slope, because people would have a right to seek second opinions, and they do. And oftentimes when we do assessments of decisional capacity, things change from day to day, or they change from provider to provider. You know, and I would encourage people to seek different assessment. But I think it's definitely dicey if you are working for the agency that's going to make decisions about perhaps rationing somebody's care. Somehow it seems that those need to be separated.
I had something as well before I give it to Dr. Griffith. The University of Toronto Center for Bioethics has a tool called the Aid to Capacity Evaluation. Are you familiar with that, and what are your thoughts about?
I have heard of it, but I'm not familiar. Are you, Katie? Do you know? There are a number of capacity evaluation tools. There's the HOPCAT, it's the Johns Hopkins Assessment of Capacity. There are a lot of them, but as I said, I mean, nobody has found the right one, the gold standard. It's a piece together kind of thing that you try to pull together the elements that you feel are going to best tap the capacity that's in question.
So I Googled the Canada case in my obsession with interactive learning. And it turns out that there was strong evidence, and in fact they're actually stroking the lower lip with so there's strong evidence the physician opines that this is purely a primitive reflex.
A reflex, yes.
Right. Any additional thoughts or comments about that even after these neurologic findings are established?
What's interesting, I mean, my first thought is that was not considered sufficient for the court. It may be a reflex, but, you know, I could see that the opponents of upholding her living will would say, once it's in her mouth, it may be a reflex, but once it's in her mouth, she doesn't spit it out. She may open her mouth, but she doesn't spit it out. You know, people lose their swallowing reflex in dementia. She still has the swallowing reflex. And I guess even though it's, you know, yes, they may be triggering the reflex, how would we know that she does not enjoy the food? You know, and I can see the nursing staff potentially arguing, she smiles when we feed her the pudding. Now, maybe they did, just like stroking the baby's cheek or whatever. They got her to open her mouth. But if she is giving some index of not displeasure, then the argument appears to be that that is honoring the present wishes of her simple self to have food in her mouth.
We'll never get to the end of
Ultimately, she will die eventually, but we just had a case at the VA, an ethics case, where one of the surrogate, well, let me back up. The person's decision making, their primary decision maker is cognitively impaired, and so they're out. Their alternate decision maker just died a few months ago, so they're out. They have two co-surrogates or alternates, and they are on completely opposite perspectives on whether or not their 90-something-year-old father should continue to have aggressive treatment for his myelodysplasia, and where he is now requiring transfusions about every 4 to 5 days. And one of them just, the daughter, who feels like this is just dishonoring her father's wishes, has now recused herself from being one of the surrogates because she feels like she cannot in good conscience see this continue, because the ethics committee weighed in on it that really, we had the man's living will, he didn't want this, we have surrogates, but even if we didn't have surrogates, he said he didn't want this. He had it written down because he actually had a clause in his advance directive stating, this is what I want even if my family members disagree with it. And even in a case like that, you can see how muddy it can get. That the physician who was the attending in charge of the case basically is like, I have two living family members who are in disagreement. I'm not going to go against them. So unfortunately, that one is still going on too.
I guess more of a comment or concern that I have is, you talked about that vital diagnostics, I think, and the insurance company like sending the phone call or calling, I think. One of the concerns that I have about that is, you know how in general healthcare now, we are now, in order to be in the healthy group, you have to participate in something that they recognize for coaching. So if you don't do the coaching, you get downgraded to your premiums. I could very well see a parallel, theoretically, that could happen, where you're sort of railroaded into this, otherwise, your insurance premiums could change. And that's a very scary thought.
It is. I think you're right. And I think that's, that's an issue of justice. Who is required to or able to participate in this? Because again, there may be people who want to and can't, and there may be others who have to or pay a huge penalty. And that's where we still don't know, with it governed by the insurance company, it's hard to imagine that they only want it to be in your best interests. They certainly have reasons to want there to be choices for less aggressive care. I know we've kind of run over time. I can be here for a few minutes if anybody has any last comments, but I appreciate everybody being here.